Okay, I'm going to talk about one of my big passions, which is otoplasty. I do a ton of otoplasty. What is otoplasty? Oto, ear, plasty, change the shape of an ear. Now, there are many ways to change the shape of an ear: cancer reconstruction, trauma, cauliflower ears. But I'm going to talk about one specific type, which is a prominent ear. That's the most common indication that I do to treat patients, is this prominent ear. There are two types of prominent ear. There is a lop ear deformity, which means this antihelical fold here is either absent or weak, it flops over, or lop ear. The second is a cup ear deformity, which means the conchoid bulb that's between my fingers is overexpressive, too large, sticking out. So it can be a combination or one or the other. I find that the vast majority are some level of a combination of both issues. There can be also lobular expression where this is too big. So that's basically the types of indications for otoplasties. I actually perform a lot of unilateral or one-sided otoplasties, and I think somehow I've become a specialist in doing that as well. So otoplasty is one of those things that I just honestly, I've looked at the before and afters online for the vast majority, even my colleagues, and I just don't like their work. I think they overdo it. It's way overpinned. It looks ridiculous. I had one gentleman that recently I had to fix. His ears were like this and his head looked gigantic. The reason he came into me, he said that, I don't mind my ears like this. I just don't like the fact that I can't put glasses on and I can't get a haircut without holding my ears out. Well, that's insane. So I said, look, I need you to functionally help you out, but also the fact that this looks crazy. Okay, I got to fix that. So I released all the scar tissue. I didn't make him perfect. He's on my website. He was kind enough to let me use his photos. But I was able to release all the scar tissue. I did multiple skin grafts to fix it. So I was able to get it better. But it's not easy to completely reverse a bad otoplasty. So let's talk about good otoplasty, which is a better subject. So how do I get these ears back? So first of all, the technique involves, it's sort of these two opposing forces. There's a force that over time wants the ear to relax, but how do you get that ear to not want to relax and have a countervailing force or force going the other direction? So we're going to talk a little bit about that. So there's also these people that talk about no incision otoplasties. I don't believe those results are very durable. There's a small segment where it can last, but I believe the incision is important because it allows me to do all the things I need to get that shape of the ear to have it last. Because the biggest thing that I don't like with otoplasty is the risk of it relaxing. So what I do, and this is something that I was actually lecturing in Germany many years ago, and I met a surgeon out there that was just really famous for otoplasties. I think he's probably retired now for the last 10 years. But he showed me this instrument. I said, oh, this is genius. It's the best instrument. I may be the only one in the United States having this instrument. So this instrument, what it does is I rasp the front of the ear here and in the conchoid bulb. Well, how do I access the front? Because here's the trick. Why do I want to rasp the cartilage? Two reasons. One, if the cartilage is really super strong, it's going to recoil out. So I need to weaken the cartilage. So when I'm rasping, I'm checking for how much recoil there is. I'm breaking that recoil, which is an important part of the mechanism of getting good, durable results with otoplasty. The second thing is, in the old days, I tried to rasp or reduce the back because it's easy. The ear is exposed on the back side. I'm working on the back side. That should be the easiest place to work with. But actually, the problem, here it is. If this is the cartilage right here. There's perichondrium on both sides. It's the lining of the cartilage. The side that you rasp, okay, the cartilage will want to bend to the opposite side. So you want to rasp the front of the ear, not the back of the ear. Well, how the heck do you access the front of the ear? And how do you score that cartilage without making cuts that are visible? It's a special rasp that I use for otoplasty. So I make a small incision in the helical rib here, and I access the front side. I rasp and weaken the antihelical fold. That breaks the recoil and allows that ear to want to go back over time rather than forward. The conchoid cartilage, I will reduce and overlap that bulb along an incision inside the backside. But now that I have an access to the front of the ear, I rasp that conchoid bulb, weakening it and also allowing it to want to go back in the other direction. So this combination of these two forces is why I think my ear results are very stable, okay? So let's talk a little bit about, what are the sort of aesthetic goals? See, I talked about overcorrecting ears. You don't want to do it. I wrote a chapter on balanced otoplasty, which means the top, middle, and third have to be balanced. If you pin this too far back, the lobe may be sticking too far out. If you pin this far back, this may look weird. So it all has to look correct. The number one advantage or viewpoint to help make an ear look good is the frontal view. So what does that mean? So what that means is how I make my assessment is I'm working on the ears, I constantly come back and look at the front view, because if it's pinned like this and it looks great on the side view, you've messed it up. It has to look good from the frontal view. Everything else doesn't matter except if the ear is buckled incorrectly. But beyond that, I'm shooting for the frontal view. So what does that mean? So if one ear, we always have asymmetric ears, one ear is going to stick out a little bit more than the other. What I've found is that when I bring the ear that's sticking farther out in, it's going to create a different curve on the antohelical fold than the other side. Does that matter? The answer is no, because the priority number one is to get both of them looking relatively the same. It can never be perfectly symmetric. Just remember that, underscore that. No way can I get two ears exactly the same. There's a little, could heal us a different way, whatever it may be, and none of our body parts are exactly symmetric. But I work as my number one goal to make those two ears symmetric. And so when one bends more than the other, the curve of the antohelical fold will look different. You say, well, wow, wait a second, I don't want to have that. It doesn't matter. Look at 50 ears. They all have a different, slightly different bend. And you really only even notice that from a side view. But when you look at one side view, you never see the other side at the same time. So there's no way you can tell that. So the answer is don't worry about that. This is the idea of prioritizing the most important elements of an otoplasty. For me, it's that frontal view, okay? What I'm talking about from the 3/4 side view is you don't want to make that front view look good. It looks crazy like this. That won't work well. From the frontal view, you don't want to have a hidden helix. What that means is here's the helix. If this is bent so far back that you cannot see the helical rim, it's overdone. So that's another telltale sign. And you need to have balance. So the top, middle, bottom poles are equally brought back in a correct degree. So the take home that I want you to know, especially from out of town or anything like that, is with the otoplasty, there's variability. I cannot guarantee it's going to be exact like this. It won't be like this or like this, but there can be a little variability with the ears. And the fact that I've got two forces, one stitch wanting to relax, one stitch wanting to tighten, I think I get the best results because I can get a net neutral balance with a little bit of variation in the results. Let's talk a little about the procedure. So the procedure itself is done under light conscious sedation. You're just basically sedated. You're enough to be talking to me, but you're very knocked out. It takes about 2 hours to do the procedure. It takes about half that time when I'm doing unilateral one-sided otoplasty. And you'll be awake enough to talk to me. Don't panic. It'll be normal. I'm going to show you at the end of the procedure your face in the mirror. But the other thing is important is you're going to have some amnesia. You may not remember me showing you that. But the next day when you look at yourself, the ears are going to be swollen, you won't remember what it looked like, or about 10% remember that I showed it to them. Either way, I like to show it to my patients. When I'm done with the procedure, I'm going to wrap you with a huge wrap, okay? And what I tell my patients is always please buy a headband that you're going to wear around the ears. The headband people think are to hold the ears in position. That's false. I like you to, it's just to help remind you not to bang your ears, especially while you're sleeping. You have to wear that 24/7 for the first week, and then at night for the first 6 weeks after that. So what I want you to do is go to Academy or whatever, buy several cheap black ones, not white ones, because some blood could get on there, and wear a button-down black ugly shirt that's you can throw away. I'm going to see you back the next day. You cannot drive home. Someone's going to drive you home. You cannot Uber home because we're giving you some sedation. The next day, a lot of people drive here because they're more awake and doing fine. If you feel groggy, have someone drive you. When you get here, I'm going to take the wrap off. You're going to feel a lot better when that wrap is off. And then I'm going to pull these drains out. You're never going to feel it. And then I'm going to give you a chuck pad that will drip a little blood for the next 2 to 3 hours. Don't panic. That's completely normal. The stitches behind the ear dissolve in about 1 to 2 weeks, really two weeks or so. Don't mess with them. They will just go away by themselves over 2 to 3 weeks. So just leave those alone. I find that incision to heal very well because think about this. Your ear is way back here, so it typically is quite well hidden. The dripping usually stops by that night. You can shower that night, so one day after, by the end of the day, you can shower. You cannot tub bathe or submerge your face underwater. The biggest fear I have is getting these stitches infected. That means no swimming, really for a couple months afterwards. I prefer 3 months, and no tub bathing below the head. You can do it here, and you can shower after 24 hours. Let running water come down. That's not a problem. Just know saunas, dirty water. That's my biggest fear is dirty water. I'm going to put the headband on you the day afterwards, take some photographs, put the headband on, and let you go on your way. I use something called Exparel. It's a long-lasting anesthetic that lasts about 3 days. The biggest thing I've found in my patients is they used to have a lot of discomfort for about 1 to 3 days. By using this Exparel, my patients have gone from a lot of discomfort down to almost nothing. And I use 2 syringes. It really has made a huge difference for my patients to go from discomfort to now very minimal. The ears do look engorged, they look swollen. Typically, they don't look quite natural for 7 to 10 days. If you have long hair, you're a female, easy. You can go back to work probably in a day or 2 if you feel comfortable and not too much discomfort. For my guys that have very short hair like myself, recovery's harder. You're not going to look so good for 7 to 14 days. So you need to know that. So a lot of people take a little bit longer if the hair is short, maybe 10 days off from work. Doesn't mean it's perfect at 10 days, but it usually is, but it could still be a little swollen and bruised. I use a product for the vast majority of my patients called tranexamic acid or TXA. It really has cut down the bruising in my patients, but you still can look a little engorged and not look quite right. The stitches I use are permanent. I have found, I've gone back and forth, and I've really been liking permanent stitches because I found that temporary stitches relax over time, the permanents don't. And the permanents need to hold for about 6 months. After that, it doesn't really matter. The permanents I use are easily removable, and so in rare cases, they spit out the incision. They're clear, so no one should see them. But in rare cases, they could spit out, and even rare cases, one could get infected. It's very easy for me to take it out, typically very painlessly. Just clip it, pull it out. Now, if you are out of town, of course, if that should occur, I would prefer to do it, not someone else. But if you've got someone you trust, they can pull it out. The reason I don't like someone else to do it is that I want to get the whole stitch out. If they're just clipping it and closed, that's going to make it really hard for me to remove the whole stitch if there's a problem. Again, that's very rare, that's an issue. What else I want to talk about otoplasty? Oh, yes, so I mentioned this, but you need to wear that headband on when you sleep, because that's when you can hurt the ears for the first 6 weeks. I mentioned that briefly, I just want to reiterate that. And buy a couple headbands, just several that you have available. The headband only needs to cover the top half of the ear, not the bottom third of the ear or the bottom half of the ear. And again, it doesn't have to, I don't want it super tight. It's not meant to try to yank your ears back, but I don't want it so loose it'll slip off your face, slip off your head when you're sleeping. Those are probably the key things. I hope you come and see me for otoplasty.